Good morning, good morning, good morning, and welcome to Health Vibes. Of course, it is a beautiful Wednesday morning here in the nature island of Dominica. And as always, on a Wednesday, we are on Q95 FM radio to bring you a health talk show with some vibes, with some energy, with some great information. We always do this on a Wednesday. Typically, Carlton Lando, our chief host, as I like to call him, would be in the house. But this morning, unfortunately, Carlton is not with us. He's not feeling well. So, Carlton, good morning to you. And we hope that you feel better. But to the other listeners of Health Vibes, to the listeners of Health Vibes, good morning to you. I see we have our online people starting to pop on. As usual, you can view and listen to Health Vibes on radio, but you can view on the Q95 FM's Facebook page as well as the YouTube channel of Q95. So if you're jumping on radio but you want to see the show, you can check us out on Facebook and YouTube as well. Now, this morning, I will be running this program with a guest that is very, very, very important. A guest that I really have tried for a long time to get on Health Vibes, and she's finally on this morning. So you all need to stay tuned to see and hear who this person is. But we will be having a very interactive discussion this morning, so you need to stay tuned for that. I see we're getting our blessings from our viewers. Good morning, Julie. I see you on bright and early. Good morning to you, and good morning to the rest of the Health Vibes crew. Jolly's Appreciation Week, Customer Appreciation Week is coming up in July. So let me just remind our listeners you need to look out for Customer Appreciation Week, July 10th to 20th. That's when Jolly's Pharmacy shows you how much we value you, the customer. So make sure in July you stay tuned to see what is up for Customer Appreciation Week. I know people are waiting for the giveaways, people are waiting for the deals, and people are also waiting for the VIP experience that they normally get during Customer Appreciation Week. But July is your time. So make sure you stay tuned. I'm sure all the treats and deals will be announced very soon. Customer Appreciation Week, July 10th to 20th at Jolly's. All locations will be celebrating Customer Appreciation Week. So we are getting set to begin our show. I'm going to bring on our guest, but before I do that, let me take a quick break just to give you a chance to share the news. As I like to tell people, share the news. If it was a Beth show, you'd be sharing it. So the Health Vibes, Health Information Talk Show, you need to share that as well. Tell a friend to tell a friend to tune in to Q95. We're about to have a very interesting show. Let me just give you a little preview. We're going to be talking about the heart. Today, we're going to be talking about heart health, cardiovascular health. So stay tuned. We'll be right back after these messages.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lando with co-hosts Jacinta Fagan Depot and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday. So be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
And we are back with you. I did promise that we'd be introducing the guest right now after the break, and now is the time to do so. I have our guest virtually. She's not in studio. And this morning, joining us on Health Vibes is Dr. Nicole Cyril Superville, who is a friend of mine and a past
Hi.
schoolmate, I would say. Nicole, good morning to you.
Hi, good morning, Trudy, and thanks so much for having me. Hopefully, you can hear me well.
Yes, I'm hearing
Okay,
you loud
perfect.
and yes, hearing you loud and clear, and I'm sure the listeners can hear you as well. Our online listeners, if you're hearing, give us a thumbs up because I'm definitely hearing you loud and clear here in studio.
Perfect.
So, Nicole, should we be saying Doctor Cyril Superville? How do you like to be referred to?
Actually, Nicole is fine. Strangely enough, because of my last name that's now hyphenated, I even make my patients call me Nicole if it's too much.
Wow.
So Dr. Nicole is totally fine. And thank you again so much for having me. We go way back in terms of our
Mhm,
college days. And I'm
mhm.
just very grateful that we finally have the opportunity to make this happen. And for me to be able to support you, I think, in such an important endeavor and initiative. So, congrats on this talk show, and I am very happy to be here supporting.
Thank you. Thank you. So now our listeners would like to know, and I didn't do an introduction because I felt it would be best for you to
Mhm.
say who you are and to talk about your work. I did give a little hint because I said to the listeners, today we're going to be talking about the heart. We're going to be talking
Yeah.
about cardiovascular health. And I
Mhm.
said I have the perfect guest to discuss the topic. So they should get a little feel already of what it is that you do. But Dr. Nicole, as you said, we'll be calling you
Yes.
today. Let
Mhm.
our listeners know a little bit about you, your background professionally, and your tie to Dominica, because I know you're virtual, so people may be thinking, okay, what is the connection to Dominica and to Jolly's Health Vibes this morning? So let us know.
Yeah, so I always say I hail from, of course, the island of Dominica, and I think I have been blessed in terms of opportunities to go abroad and make an impact, and hopefully trying to contribute in different ways. St.
Okay.
Martin's Primary School. Went to convent, went to Sifakol, and was fortunate enough to go beyond that to complete studies in Texas at Midwestern State University. By no way I ever thought that medicine was going to be where I ended up. I taught grammar school actually for 1 year in terms of being a teacher for my first job. But the more and more that I studied, I really fell in love with the aspect of taking care of patients, being on the front line, and not just in terms of the clinical aspect, but also in terms of research, in terms of what comprises my career currently. So I went on to do my studies at Columbia University in New York in terms of medicine. Became a chief fellow at Montefiore Medical Center in the Bronx, New York, and then had the opportunity to do advanced heart failure and transplant cardiology at Massachusetts General Hospital in the Harvard system before moving to Charlotte, North Carolina about I guess the time really flies. I think it's been about 7 years now as a practicing attending in the field of heart failure and transplant cardiology. I know it's a mouthful, but long story short, I think when patients exceed or we have nothing else to offer patients from a medical perspective, a lot of times they come to providers like me in terms of thinking about things like heart pumps or transplant and so forth. So that's currently what I do
Okay.
from a cardiology perspective, but we see all comers from patients suffering from end stage heart failure due to high blood pressure, due to valve disease, due to abnormal heart rhythms. It's really a great breadth in terms of the field of patients and type of patients that we see.
Wow. So interestingly, your specialty cardiology,
Mhm.
um, why that area? Why did you gravitate towards cardiology? What was the pull?
So, in medical school, I felt like it was one of those areas that it was really dynamic. It's a field that's ever changing in terms of cutting edge. Unlike some of the other fields also where it takes a while sometimes to see a patient respond or turn around and that immediate gratification that you get as a provider, a lot of the times the interventions we provide, you can see a lot of quick turnaround in terms of your patient population. I
Mhm.
think the patients that we get to serve as well is really a unique population whereby you are able to develop quite a rapport. You're able to follow patients longitudinally. You're able to counsel patients in terms of lifestyle modifications, apart from just, pharmacotherapy or medications. So I think it's a field that is really, really rewarding in terms of cardiology and heart disease. And again, something that is very prevalent, very relevant in terms of when you think about all of the lifestyle opportunities we have an opportunity to impact and change. So it's just a field that I fell in love with.
Okay. My question, because what is striking me about some of what you're doing, advanced heart failure,
Mhm.
transplants. What about the dealing with losing patients and the definite chance of that in that area of work? How do you deal with that aspect?
So it's funny enough that you say that because I feel like even for some of my other colleagues in different subspecialties of
Hmm.
cardiology, I think they look to us a lot when it comes to discussions of end of life.
Hmm.
And just to clarify, that's probably what you meant when you said in terms of losing
Yes,
patients.
yes, it was.
Yeah. I will say for me, I think I've gotten very well versed in terms of having those tough discussions with
Okay.
patients. I think I have seen a lot in my career, and probably every heart failure cardiologist will tell you that, where sometimes what we have to offer patients may seem like the magic fix but we also get to see the opposite of that, right?
Hmm.
Where we take patients onto therapies, and though our hope was for things to go well, they don't necessarily turn out as we planned. And so I think being very open with patients in terms of benefits as well as risks have become sort of second nature to what we do. It's always a difficult discussion, but I do think there is something to be said about um, you know, being frank with patients about therapies they may benefit from, or
Hmm.
sometimes it may actually bring them more harm.
Okay.
And framing that discussion sometimes, mostly in the sense of sometimes quality of life and not just longevity. Yes, I can probably offer you a therapy, but will it really add to your quality of life? Or maybe it may actually add more suffering to whatever time you may actually have left. So I think we have a lot of support when it comes to end of life discussions. We work with our palliative care team. We have a lot of support for patients that help guide those discussions. And I mean, it's never an easy thing. I think it's always difficult. You're always talking about somebody's loved one. But I do see sometimes that there's actually benefit sometimes in just saying, hey, let's make things take their course. It's hard to say how things may go, but what we do have to offer may actually add more suffering or may not add benefit at all.
Okay. All right. I asked because I know oftentimes people might shy away from
Mhm,
particular areas because they feel like the risk is higher
mhm.
for certain outcomes. So there is, a little hesitation when it comes to choosing what area you may want to go into
Yeah.
because of that. So I
Mhm.
was just curious about how you approach it
Yeah.
and how you were able to navigate that aspect of your profession and your career.
I mean, our goal, honestly, we try to save every patient that walks
Save
through our
lives.
door.
Hmm.
We always try to make sure we do our due diligence. We try to be very thoughtful about every option a patient may have. But truth be told, sometimes there are no options. And then what do you do? And I think one of the most important things in medicine and the way we practice is to always be forthcoming with patients, to always be aware of our limitations. I had a senior partner who said to me once, not because we can do something, it means we should.
Mm-hmm.
And that's always stuck with me because there's so many things sometimes we can do. But when we think about the benefit to the patient in terms of what we're bringing to the table, I think that should always be first and foremost.
Mm-hmm. Okay. All right. I wanted to get into a discussion with you on things. Of course, we said we're speaking heart health this morning. We're speaking cardiovascular health, but I want to really delve into certain areas that I know locally pose significant problems. One of the things I wanted to bring to you this morning, Dr. Nicole, is the whole aspect of dealing with the very common chronic disease, hypertension, and its impact on cardiovascular health as as a disease of the blood vessels. Essentially, what is the impact that you're seeing, and what is it that we have to look out for as it relates to hypertension? I know, as I said, the prevalence is very high in our setting here in Dominica.
Yeah.
What I want us to go a bit into that and treatment thereof. There's so
Mhm.
much said about hypertension because it's such a
Yeah.
common condition,
Yeah.
and there are also a lot of misconceptions and a lot of bad information that floats around. So I wanted to use the opportunity on this show to set certain records straight and get the information really out there about hypertension and its impact on the heart and cardiovascular health in general.
So I think that's a great topic
Mhm.
in terms of trying to delve a little bit more into one of the things we have the opportunity to modify behavior around when we think about cardiovascular disease and health. And let me just say, in terms of prevalence, again, we see it here as well in terms of where I practice,
Mhm.
particularly around Black African American patients and, of course, Afro Caribbean patients. So it's very prevalent, and you are right. There is so much we can do in terms of addressing high blood pressure. A lot of the patients that we see, even in our heart failure clinic, I always counsel them that it is one of the most, if not the most, when you think about certain populations, most common cause of the heart failing over time. And the thing with high blood pressure, a lot of times patients feel well until they don't,
Mhm.
or until it's caused a lot of damage in terms of different organ systems. And of course, I am very biased to the heart because that's particularly what I see. So I can start there in terms of, the impacts on the heart itself. But even
Mhm.
before I do that, again, high blood pressure can have so many devastating impacts on different organs. When we think about the risk of stroke in terms of the brain, and not just in terms of blockages, but also deadly bleeds in terms of if you have an aneurysm rupture because of things like high blood pressure. When we think about the impacts on the kidneys in terms of how it changes the vasculature there and may lead to things like kidney failure. When we think about just the peripheries in terms of your vessels in your extremities, when we think about peripheral artery disease or blockages there are so many bad things tied to high blood pressure. I think it is absolutely one of the most important things to address. But just circling back to the heart, so it can be a risk factor for many different types of cardiovascular disease. One, when we think about things like coronary artery disease, meaning blockages in the vessels that line the heart and supply the heart muscle with blood flow. That's certainly a risk factor there. When we think about, the heart having to pump against a very high blood pressure over time, it may also start to weaken, and patients may end up with things like heart failure, which is what I predominantly see over time, where the pumping function of the heart is reduced. So when we think about just the comprehensive impacts of high blood pressure, I think it is absolutely one of the things that we certainly need to address in many populations. So happy to kind of delve a lot more into this topic, this morning.
Yes. Um, you mentioned the impact on multiple organs, and yes, the heart. What my next, a lot of people will say, I have a little pressure, or people will say I have a touch of high blood pressure, or
A
people will
little
just sometimes
sugar.
say I have, yes, just like they say I have a little sugar, or people will say I have pressure, but is not all the time, or things like that. My
Mhm.
question is in defining a hypertensive patient. What is the definition? What is the definition that people need to understand means that yes, I am hypertensive, and
Right.
what are the actions that need to be taken
Mhm.
thereafter?
All right, so that's a great question because you may go to your doctor and you have one isolated elevated blood pressure reading, and does that really say, hey, you have high blood pressure? So let's start with the definition. So normal blood pressure is 120, less than 120 over 80. When
Mhm.
you're thinking about the top number, which we call the systolic number, 120 to about 139 is probably pre-hypertensive, and about 80 to 89 is about pre-hypertensive on that bottom number, the diastolic number. So just in terms of definitions, that's what we're looking at in terms of a range or an idea. You are
Mhm.
right in that you have to have repeated readings. It has to be at least two readings. But when you think about the time frame for the two readings, actually, it's not even over months or days. It's like, hey, have I taken your blood pressure like multiple times while you're here at the office? And it's certainly elevated. So, again, it has to be repeated readings. I wouldn't say, hey, let's wait a month or 2 months to like check your blood pressure again to kind of, make the diagnosis. But certainly, if you have persistently elevated pressures above the ranges that I mentioned, you should be taking note in terms of your blood pressure and what other things can control in terms of trying to work on lifestyle modification. And some of my patients come to me and they're like, Doc, isn't there some herb I can take? Isn't there
Mhm.
something I can do? And the first thing I always ask them is, are you from the Caribbean? Because that would probably be the questions I would get if I was home. So, ultimately, there are things we can change lifestyle wise, but the majority of patients do end up on blood pressure medications, which we can talk about. So let's first hit in terms of lifestyle modification. What are the things we can change in terms of our daily living, in terms of minimizing, our risk for high blood pressure? Um, I will say sometimes genetics play a role in terms of what we call essential high blood pressure and patients having a family history of high blood pressure. That you can't necessarily modify. But in terms of things like obesity, right? Making sure we keep our weight in a certain range. Obesity is certainly one of the risk factors in terms of high blood pressure. The other thing I would say is diet in terms of salt. And a lot of times, people think of salt intake just as me using a salt shaker or the salt that I add to my food. But, there's hidden salt in so much that we take in, especially if we use things like canned foods. So, the Vienna sausage, that canned tuna. Those foods actually have a lot more sodium than you would probably put normally in your meals when you're cooking. In the Caribbean, we don't necessarily have the culture of a lot of fast food, so to speak, although
Mhm.
KFC lines are usually pretty long
Very
when
long,
I'm back
very
home.
long.
But certainly eating out in terms of sodium, content in fast food, in terms of canned foods, those are certainly things that sometimes we don't appreciate because we only think about added salt to food. So watching sodium or salt is actually very, very important in terms of how your body responds blood pressure wise. Other factors, of course, include smoking. That's also another risk factor, and alcohol. So
Mhm.
alcohol consumption is also very big in terms of risk factor for high blood pressure. So when we think about that first initial list, when we think about obesity, when we think about salt intake, when we think about alcohol, when we think about smoking, those are all things that we have the ability to modify.
Mhm.
Genetics is very limited what we can do here, but those are things that patients can work on even before they say, hey, I'm committed now to having to take medications.
Mhm. And well, as it relates to diet, so those modifiable risk factors, the diet,
Mhm.
the weight management, and so on. The diet in particular, the impact of culture is also very strong because you just spoke about our culture towards fast food, which is definitely changing.
Yeah.
But our culture of, for instance, in our traditional meals, using these salted foods that were preserved with salt, like your salt fish and
Mhm.
your
Yeah.
yes, your salted pigtails or your salted, all we use a lot of those things. So
Mhm.
culturally, I think we also have to start to rethink
Yeah.
some of the norms in
Yeah.
our eating, because people might just, this is what we normally do. It's saltfish
Exactly.
this and it's
Mhm.
salt meat, that, and it's just normal for us. But
But I will tell you, and I think it's one of the, the diet part is usually one of the hardest things
Mhm,
for patients to really get used to.
mhm,
But I will tell you, if you commit to it and you do it over time, a lot of patients find themselves becoming so sensitive to salt
to salt,
that they will start tasting things and be like, oh my God, this is just too
so
salty.
salty.
And for example, a small thing like I noticed it even on my own during the time of COVID when restaurants were, not a thing or people were at home. And even I myself, the first time, once or, first occasion I went back to a restaurant, I was like, holy moly, this is really salty.
Mhm,
Because had gotten so used to cooking at home again, where my husband, for some reason, just never cooks with salt. It's
mhm,
always just natural seasonings. So I think the more you adopt it into your daily living, it's gonna be hard in the beginning, but over time you become a lot more sensitized to
mhm,
sodium intake, and that's actually one of the biggest things we can do in terms of hypertension risk.
mhm. Now, what about what age should we start monitoring our blood pressure? For instance, I
Mm.
work in with young people.
Yeah.
I've been in education for a long time. Anytime there's a health fair or something and it's done at school, the young people will not be showing up to check their blood pressure and their blood
Mhm.
sugar because they figure, what issue could I possibly have? You always get low turnouts for those things amongst that particular population.
Yeah.
What age is it that we should be monitoring our blood pressure? That's what we're on, the blood pressure.
Yeah. So that's another good question. I think for one, a lot of it may also depend too on family history.
Okay.
If you have a family history of high blood pressure, sometimes you see it start even as early as your 20s.
Hmm.
And you bring up a really good point in terms of just early preventative care, as opposed to, hey, going to the doctor only when you feel unwell or when you have a problem. It's like, how do we incorporate these types of screens early on, so that our younger patients or younger persons rather get in tune with, hey, being on top of their health, and kind of changing what I call generational health,
Mhm.
as we move forward, into the future. So I think one, certainly if you have a family history of high blood pressure, when you start going for your, healthcare visits, be it in your 20s, they should be starting to monitor things like your blood pressure. People who just have essential high blood pressure, we see it present mostly by the time they're in their 20s to 50s range that we start seeing those elevated blood pressures. And I
Mhm.
will say, just to take another step back from just the routine high blood pressure, there can sometimes be secondary causes of high blood pressure that I don't want to miss the opportunity to also bring up here. For example, sometimes you can have blood pressure that's elevated because of certain medications, some
Mhm.
types of birth control sometimes.
Mhm.
I'm in the transplant there are medications we put our transplant patients on that can cause their blood pressure to be elevated. When you think about pregnancy, that's another area where blood pressure should certainly be monitored in terms of gestational hypertension or even things like preeclampsia. So
Mhm.
monitoring it in our young women when they're pregnant is also
Right.
pretty important. There are hormonal things that could be abnormal that may cause patients to have very high blood pressures. So when you see blood pressure in younger persons, apart from just saying, hey, family history, we should always think about secondary causes of high blood
Mhm.
pressure, and ruling those things out. Even drugs can cause very high blood pressures in
Mhm.
terms of things like cocaine use. So, in terms of getting talk screens and counseling, in terms of, any type of bad habits. So, when we see blood pressure elevated, especially in younger persons or really unexpected, apart from just thinking, hey, this is family history, I don't want to neglect the fact that there are also secondary causes why somebody's blood pressure could be elevated.
Could be high. Okay. So the next area, the discussion about medication. So somebody has been diagnosed with hypertension and possibly they have tried certain lifestyle modifications. They have been their blood pressure has been elevated for a prolonged period. The doctor says to them, this is the medication
Hmm.
I want you to take. There tends to be a lot of resistance
Yeah.
surrounding taking blood pressure medications. As a matter of fact, people will advise you to not take the medication because it's
Hmm.
not good to become dependent on it, or for men there are some reasons that they may want
Yeah.
to avoid
Mhm.
taking the medication. um, so there is a lot of resistance. I just I hear it anecdotally, people are talking and you just hear, why I'm not taking that, or the doctor said I should take that, but I will try this whatever instead. I wanted to your take on this prescription medication uh,
Mhm.
treatment for hypertension.
Yeah.
How important it is to be adhered to. What is the recommendation in that
Right.
regard?
Yeah, so I think it's always a tricky topic with patients.
Hmm.
For one, I always discuss again the things that you can modify. And if you really don't feel, hey, we want to get on medications at that very moment in time, and it's not open to that, we go through your risk factors and say, hey, we'll give it some time period. Let's work on these, and then let's see where we end up. Again, for the majority of patients, they will still likely end up on blood pressure medications. Um,
Hmm.
and I always put it as, there is a lot that have been studied in terms of medications that we recommend to patients. A lot of them actually come sometimes from plant extracts over years that have been studied. And at least they've been studied in a way that we actually know how they improve the blood pressure, but also know some of the side effects that we can work with patients to address if they arise. So I know it's always hard for patients to think about, hey, I have to be on a daily pill. But to me, having that open discussion about the complications or even your mortality if you choose not to have your blood pressure controlled really has to come to the forefront. And again, just to reiterate, we're not just talking about cardiovascular disease as it pertains just to the heart. We're talking about strokes that can be debilitating in terms of never being able to speak again or function in terms of, being able to participate, move your limbs. We're talking about kidney failure when you may end up on things like dialysis. We're thinking about peripheral vascular disease where you may have claudication that's so bad in your legs that you're unable to walk. So I think the end result of poorly controlled high blood pressure really needs to be stressed to patients, as opposed to, hey, trying to introduce a medication that may keep your blood pressure controlled and in the long run save you a lot of morbidity and even mortality in terms of your risk of death. I do understand, especially for some of the medications, they may have potential side effects. But usually we have quite a number of options when we think about blood pressure management that we're often able to work with patients in terms of something that works for them.
Mm-hmm.
Our choice of blood pressure medication sometimes may also be dependent on what other diseases somebody may have. For example, if they have diabetes, we may prioritize, hey, you may benefit more from what we call an ACE inhibitor or an ARB, something like lisinopril or losartan. If you've had coronary artery disease, for example, we may prioritize an ACE or ARB, or we may prioritize something like a beta blocker, which is more of those medications that ends with alol, like metoprolol, atenolol,
Wow.
those sort of medications. And those are the ones that usually the male patients are usually very unhappy with,
Okay.
in terms of things like erectile dysfunction, which we also have ways to, address and talk about it all the time with our patients in terms of what may be helpful. Do we modify the dose? Do we try a different drug in that same category? Because again, there's usually a number of medications within that same category that can be tried. Do we engage your primary doctor in terms of things that may be helpful to address, the symptom that you're having while we continue the medication? So I think it's really about, again, having an open dialogue.
Mm-hmm.
A lot of times patients also raise the question of, well, do I try this herbal remedy? And the
Mm-hmm.
thing is, those have usually not necessarily been studied in such a way that we can say for sure that it's going to be beneficial to you, or, we don't necessarily know all of the side effects that may come from, different herbs. And some of them do have side effects in terms of the liver, depending on what type of herb you're dealing with. So I think, we as providers, we kind of are well aware a lot of times of the complications, the risk. A lot of times patients are feeling well, and so they don't necessarily foresee the situations that may come from not being on medications and having their blood pressure, well controlled. And we really have to be very open with them about that in terms of trying to get them to take medications.
Mm-hmm. I do see we have listeners who are giving some feedback. One of our listeners is, referring to the side effects that are horrible of blood pressure medications. But doctor, you did just, state that there are different options and that you can, because the side effects might be horrible with one, but possibly,
Exactly.
you could alter dose, or you
Mhm.
could alter medication for reduction of those side effects. And a listener is also saying that women also experience reduced libido, she's saying, from
Mhm.
using
Right.
medication. So it's not just a man's issue.
But I always
But
tell patients too, though, if you ain't around, there is no room for even a libido, right? You gotta be around and alive. Maybe not
right.
stroked out, or so it's also weighing that risk.
Mm-hmm.
and trying to see, hey, and we do, I mean, I personally try to do my due diligence to see like, hey, how do we work around that? But
Mm-hmm.
at the end of the day, and there, that's where it also goes back to patient-centered care, right? Somebody
Mm-hmm.
may say, hey, I really don't necessarily care about how long I have left. I'm focused on my quality of life. I
Right.
want to go out with a strong libido. And then you're like, well, if that's, the priority to the patient, that also frames how you approach things as a provider. But a lot of patients, of course, want to be around for a long time,
Mm-hmm.
and don't necessarily just think about the quality of life. And sometimes that gives you an opportunity to approach things a little differently.
Right.
So I do think it's one, listening to the patient, getting their perspective, prioritizing sometimes the things that matter to them.
Mm-hmm.
And that to me comes into play also when you've really presented them with everything that's on the table, what we're
Right.
dealing with, where we're at, what may come, and then trying to make a joint decision in terms of where do we go next with medications.
Mm-hmm, mm-hmm. It's interesting because we're speaking this in relation to health and choices of treatment and so on. But the same applies for shopping around. For instance, I was shopping around for a phone, and people were trying to tell me about this feature and that feature that's so great, and I'm really not interested in that feature. My interest is in the camera and how it works. You know what I mean? So people really have to have that open discourse with their practitioner, as to what it is that they want to prioritize. And
Yeah.
I like the point. Is it longevity? Is it quality of life? And I do see people, for instance, bringing up issues with medication, and these things are so important to discuss with the physician. So someone is talking about being on a diuretic, a water pill,
Mhm. Yeah.
as she called it, and saying that it makes you go to the bathroom every 5 minutes. So
Hmm.
this
Yeah.
apparently is an issue for her. So people are
Hmm.
having different concerns about their
Right.
medication, and I
Mhm.
think the
And
discussion.
those are all very valid concerns. As
Hmm.
I tell my patients all the time, I'm trying to put you through all this, not so that you are at home or feeling poorly. The goal of us trying to care for patients really is to get them out there living their best life,
Hmm.
feeling well and actually being active and doing the things that they want to do. So I think open dialogue is really important with your care provider because there are so many options right now in terms of, again, treating high blood pressure. There are so many things that we can modify in terms of lifestyle as well to kind of support our efforts apart from just medications, um,
Hmm.
that we really have to be upfront as to how we approach patients. There are going to be patients, though, where their blood pressure is really what we call refractory. They're going to need multiple medications in terms of trying to keep that blood pressure under control. And sometimes it becomes a little harder in terms of, giving that wiggle room to say, hey, I know you're urinating a lot on this, and my hope would be to stop it, but hey, we don't even have the room to do that because of where your blood pressure is. And of course, in that setting, you would hope that the patient themselves have modified their behavior
Hmm.
in the best way that they can to help get them to goal in terms of where their blood pressure is. For example, that diuretic, like the hydrochlorothiazide, which is the most common one in terms of having a diuretic effect, if that's the issue, or chlorthalidone, hey, do we switch to something like amlodipine? Do we switch to an ACE or an ARB in terms of, trying to mitigate some of that effect of the diuretic? What time of day are you taking your medication? A lot of times we'll tell patients to take it maybe in the morning so that you get all your urinating done before you're up and going throughout the day, or you're not having to wake up a lot during the nighttime, which of course can affect sleep and quality of
Hmm.
life. So even those little things, in terms of as a provider trying to modify, we try to do at least all that we can, hopefully, to get patients to be compliant with medications with the proven benefit, down the road.
Right. I was just saying I'm having interaction from our online viewers. Let me give the numbers so those listening on radio can also interact. If you want to interact with Dr. Nicole Cyril Superville, who we have as our guest today, we're talking cardiovascular health. We've been talking hypertension so far, but we're going to delve into some other topics shortly. But the numbers 449-3095, 449-3096. 449-3097 and 616-4257. If you're trying to reach us from overseas, the overseas line is 305-432-9624. So I just want to give our listeners a chance, an opportunity, if they would like to call in to interact with the doctor, that they can do so. I do see that we had some people trying a bit earlier, but you can try again. So, doctor, I know the hypertension conversation would generate interest because, as I said, it's such a common issue that most of us have some sort of experience with it, if not personally, but with a family member or friend. And it's definitely something that we need to keep on the table as it relates to health education and discussion. Um,
Mhm. And there's
but
a reason, Trudy, why they call high blood pressure, not to interrupt you, the
Mhm.
silent killer. Because a
Uh-huh.
lot of times patients feel okay until something really devastating happens, most times a stroke or their heart gives out. So
Right.
again, I think it is just a very, very critical topic, especially when we think about us in terms of African descent, in
Mhm.
terms of addressing, given this is one of the highest risk factors for a lot of cardiovascular disease.
Right. I see we have a call on the line. Let's take this call. Okay. We're trying to sort this out, but we will be taking the calls shortly. I do see people are trying to get us, but we'll be taking some calls shortly. I do want people to get the opportunity to interact with Dr. Nicole. So you can try. We're going to sort it out to take your phone calls as they come in. Okay. So we are talking cardiovascular health. Doctor, I wanted to move on a bit into specifically conditions that you would see in your practice resulting in the need for a heart transplant,
Mhm.
or for, as I guess you will explain to me how, and to our listeners, what would cause somebody to require a heart transplant, what necessitates that level. So let's shift gears a bit, although I know maybe the people who are trying to call in were trying to interact with hypertension, but we can switch back. But let's switch gears a little bit now.
Mhm.
Hmm.
So, I always say, all roads lead to us in terms of heart failure cardiologists when a lot of other things have been exhausted.
Hmm.
So there are two different types of heart failure, just to take a step back.
Hmm.
One where we think about the pumping function of the heart failing. So we've got something, for example, called an ejection fraction. That means just a percentage or proportion of the heart, the blood that the heart receives that goes to the rest of the body to supply your organs, such as your kidneys, your liver, your muscles. And normally your heart should probably eject about 50 to 70% of the blood that it receives to the rest of the body. So
Hmm.
the most common type of heart failure that we see, whereby patients sometimes eventually need a heart transplant, is whereby the ejection fraction of the heart is extremely low. The heart is unable to really pump forward a large proportion of the blood that comes into it. a lot of times patients' hearts are ejecting less than 25% as opposed to the 50 to 70% that it should. And there are many different reasons why patients' hearts can fail. Um, the first one being blockages in the vessels around the heart that supply the heart muscle. So what we call coronary artery disease. If there is no further room to kind of relieve those blockages, or patients have been on medications over time and things aren't really working well, the heart can continue to fail to where we have to think about replacing the heart. And that may be with a transplant, as you raised, but it could also be for patients who are not transplant candidates. We do have different heart pumps that patients can live on. Apart from coronary artery disease, hypertension is probably the second most common reason as to why patients develop heart failure over time. And as I said earlier, just imagine the heart having to muscle up to pump and force blood out against high pressures. Over time, the heart may weaken to a point where, medications may not necessarily reverse or help anymore. So these are probably the two most common reasons. Other than that, there's sometimes genetic reasons or familial reasons. Patients are born with genetic abnormalities where the heart may become weak. Sometimes patients may have issues with the valves of the heart if they're very stiff or their valves are very leaky. And that leads to the heart weakening over time. So there are many reasons for that specific type of heart failure, which we call systolic heart failure, weakening of the pumping function of the heart. Less often, we have to consider patients for heart transplant whereby the pumping function of the heart is fine. For example, a population of patients I see that have amyloid or a protein that's depositing into the heart muscle, the squeeze is usually normal, but where we see the problem is with the way the heart stiffens, or it has abnormality in the way that it relaxes. So it cannot receive a lot of blood to pump forward, and patients suffer in terms of symptoms of heart failure, or they may also ultimately need a heart transplant. And when we talk about symptoms of heart failure, that really drives a lot of the decision making as to whether or not your medications are working well or whether we're beyond medications. So when the heart is unable to pump blood forward, there's two aspects to that. One, things start to back up, where patients feel, oh my God, I'm short of breath, because the heart's unable to pump blood forward, and patients can't lay flat at night. They often feel like, hey, I have to prop my head up with pillows because fluid is building up with the lungs. Fluid may back up so much that patients start to see a lot of swelling in their legs over time. Or sometimes it becomes so bad that they feel like I can barely eat because their gut is really full of fluid. The second aspect to that is because things are backing up and nothing is going forward, the other organs are not getting enough blood flow. So then on labs, we sometimes see the kidneys start to get unhappy, the liver starts to get unhappy in terms of their functioning. Patients start to feel very weak or fatigued in terms of not being able to do much. Sometimes they get to the point where they can barely get dressed or take a shower, which is all of the things that we start to look at. Because the blood flow is not really going forward, blood pressures start to become much lower. And so for some patients whereby you started off being able to tolerate blood pressure meds, which we use sometimes to support the heart, you find that they're no longer able to tolerate that, a sign that the heart is getting weaker.
Wow.
So we look at those signs very closely for a lot of our patients in terms of guiding us as to, hey, do we need to kind of further evaluate to see if that patient needs a heart pump or a transplant? And what we do is a lot of times, apart from just trying to get fluid off with diuretics, and getting patients to pee a lot, and optimizing their blood pressure and so forth, we sometimes are able to do what we call a right heart catheterization, where we can float catheters in. We can actually get direct measurements of the fluid that is in the heart, and also calculate the exact amount of blood flow that the heart's pumping. And based on those numbers, we're then able to say something, hey, do you need a transplant or do you need a heart pump?
Mm-hmm.
So
Mm-hmm.
it's a lot that goes into trying to consider patients for such advanced therapies.
Mm-hmm.
It's never something that we ever bring up. We try to bring up too soon. We try to exhaust everything that we can before we make a decision to say, hey, we need to crack your chest and replace or take over your heart function. But at least it's an option for a lot of patients when medications aren't working. And we know that, things like putting them on IV pumps and trying to pump the heart, that have not shown a lot of longevity for patients, at least we have those as options for treatment.
Mm-hmm. I mean, it would be interesting to know locally what obtains in terms of treatment procedures that we can do, because of course
Mhm.
the local context would be different from yours. But doctor, do you, like, where you're based, are patients accepted from overseas, or are patients who typically are experiencing heart failure unable to go to a different country for treatment? Is it common that you would accept somebody or accept a patient from overseas, or do people have to basically stay where they are because they cannot risk travel?
Yeah, so that's a great question, and really one that weighs on me a lot, because a lot of times you see the capabilities and the access that patients have here, and you always wish that it was a little bit more widespread.
Mm-hmm.
And I think that's where programs like what you're doing is just really invaluable, right? Because we don't want to necessarily be patients where you're seeing me at the end of the road.
Right.
The opportunity to really change the things that we can very
Mm-hmm.
early on,
Mm-hmm.
and be very thoughtful and preventative, where we don't have access to a lot of this, becomes very critical. Because again, as you're alluding to, it's very challenging sometimes to get patients up here, especially when we think about insurance coverage
Mm-hmm.
and the cost of
The
healthcare
costs. Yeah.
up in the States. And, again, with even more that's going on now in terms
Mm-hmm.
of citizens' right or permanent residency and what people are eligible for, it becomes very complicated sometimes. We've had one or two cases where the companies or people of the heart pumps have donated pumps to patients, or we've had a couple of those incidents, which has been great for some patients and their families, but that's not necessarily the norm. Certainly, I have discussed with patients, or at least giving counsel sometimes, to going to some of the larger islands in terms of therapies that may be needed, be it things like getting an angiogram or consideration for a stent placement in terms of trying to keep the heart function in a great place. But there's certainly a number of challenges when we think about the access for patients who do not live here. That is a lot of times very, very heartbreaking.
Mm-hmm.
We sometimes do send patients out on medications through IV pumps that can help to sustain their heart, help with the squeeze. And some patients do okay on that, and we're able to get sometimes charity care in terms of supporting some of these patients. But I will say there are many hurdles in terms of having access to some of the care. And so prevention
Mm-hmm.
is
Mm-hmm.
key,
Mm-hmm.
right? trying to do all that you can, because again, when we think about cardiovascular disease in adults in particular, a lot of it comes from behavior, lifestyle modification, trying to do the things that you can. When you're young, you don't necessarily think about all this,
Right.
and a lot of times we don't necessarily even think about getting things like health insurance.
Mm-hmm.
So I think we have to really be very proactive, as opposed to reactive when we're in situations where resources may not be as accessible. And my hope is, that changes in the future. Things look differently. But for now, it is very challenging, I would say, to offer some of these therapies to beyond the shores of where we are.
Right, right. And yeah, very, very important. The need to be proactive, particularly in resource scarce situations. Because, and just in terms of population too, there are some things that, we don't, health wise, that is, we just don't even have the population to necessarily support. So the idea of prevention is a definite
Yeah.
one that we should be holding on to. So yes, I really like your call to action with that. I have a question that I think I put it back a bit, but let me come forward with it now. You spoke about congenital issues that may occur, that may cause, that congenital issues with the heart. Um, in Dominica, people often say, or there's a common saying that a child was born with a hole in the heart. Now,
Mhm. Yeah.
in me teaching anatomy and physiology, that is always a thing a student would ask, like, where is the hole that the person is born with in the heart? Because it's just a thing that people say, a child was born with a hole in the heart. So, doctor, I want to give you the opportunity to speak to that particular congenital effect that people may be referring to when they speak to a hole in in the heart.
Well, I will tell you that is a major oversimplification
Mhm.
when you think about congenital heart disease, because there's so many areas in the heart where you could be referring to in terms of a
Mhm.
whole. um, so, you can have, of course, holes between the left and the right chambers of the heart. It could
Mhm.
be between the top two chambers, it could be between the bottom chambers of the heart. You may be having, so there's a lot of different configurations in terms of
Mhm.
congenital heart disease. It's actually a whole specialty all by itself.
Wow.
And I will tell you, children actually get different types of echoes or ultrasounds compared to
Mhm.
adults in terms of trying to figure out where the holes may be, or the different connections you can have in terms of the vessels. You can have children that instead of having two bottom chambers, they have only one. And
Mm.
so that hole is actually necessary in terms of trying to play the role of blood flow through the lungs and through the body. So, when we say a hole in the heart, that is maybe the most simple way of saying something is wrong in terms of action or holes, but congenital heart disease is very vast.
Mhm.
And there's some where, they're minor, or let me rephrase that, maybe relatively minor. For example, one of the more common congenital conditions we see is the aortic valve, the major valve that blood pump out through from the heart to the rest of the body, being instead of having three leaflets, it has two, what we call a bicuspid valve.
Mm.
That's not that's relatively common in terms of a congenital heart disease, but a lot of times patients have normal lives until they're much later in life, where the valve begins to stiffen. So you can have that type of congenital heart disease, and then you can have severe congenital heart disease, where patients are missing different chambers, or
Mhm.
connections are all, so a hole in the heart is it could be a number of things, and again,
Mhm.
that's where we talk about, access, because be able to do things like cardiac MRI, um, having CT scans readily available to look at the connections, to look at the vessels where they connect to the heart, having even the ability to just do a special pediatric echo where they do a lot more sweeps of the chambers, as opposed to as an adult, you're just really looking at the heart in still pictures. So it's a field on its own. Let me just say that. So
Mhm.
it can be very complex, much more
Yeah.
complex than a simple hole in the heart.
Yeah, I mean, I think it would be interesting. I did not realize there was an entire field just for congenital heart defects, but
Yeah.
I think it would be interesting, particularly people studying, as I mentioned, my students who, well, I don't teach
Mhm.
A&P anymore, but when I did, to visualize some of the defects, because I typically got the impression that when people said a hole in the heart, the students would think we're talking about
Mhm.
blood gushing out of the heart. So the hole being in the wall of the heart and blood is just gushing
Right.
outside of the heart. So
Oh
that's what I
no,
feel.
no.
Yes. So that's what I feel is the typical. That's why they would ask, like,
Mhm.
Miss, like a hole in the heart. Like, what is
Mhm.
what is going on?
Yeah. So
Yeah,
a
that is
lot
the.
of the time it's imagining, the heart in 3D, and the
Mhm.
chambers. So most of the time I think what people are referring to when they talk about a hole in the heart, it's usually probably shunting from most times one side of
One
the heart
chamber
to
to
the
another.
other,
Mhm.
either through the division that should be between the top chambers of the heart and the bottom chambers. That would
Yeah.
probably be the simplest thing when we refer to a hole in the heart. So we can see these type of atrial or ventricular septal defects. So the septum separates the top chambers, and another septum separates the bottom chambers.
Mhm.
And that's probably, holes that can also be very readily addressed. Some of them in childhood. I actually had a friend of mine the other day whose baby was diagnosed with Down syndrome in terms of when they did your genetic screen. And some Down syndrome patients very commonly have a hole in the heart in terms of atrioseptal defects. And they were, as soon as the baby came out, in a matter of months, they kind of fixed it.
Wow.
And then some times now we have even the ability to fix things in utero, while the baby.
Yeah. We have a little, I believe, a little internet issue, Doctor, where you have sort of frozen for a bit. Let me see if you will get reconnected with us here. But we have been really enjoying this discussion. I do know that we were not able to take some of our calls, but we are already in line to wrap up. I think we lost Dr. Nicole Cyril Superville. I don't know if she will be able to come back on. Um, but yes, we are at the end of the almost at the end of the program. If we get Dr. Cyril Superville back on, she will just close. But she has been with us for the
Oh,
duration of the show. Yes, she is back.
okay.
Yes, we lost you, but
Sorry.
I was telling our listeners that we've been talking and we are actually almost at the end of our time. So when I
Oh,
get you, yes, so when I get you back, it would be just to essentially wrap up. But yes, continue if you want to
oh no,
continue
but
because
I was honestly, I was just saying, like, the hole in the heart, again, it can be very complex in terms of congenital heart disease. And so
Mhm,
it's a very fascinating field and has grown so much over time, that
mhm,
a lot of these patients actually go to our adult congenital heart disease specialist, or
mhm,
in the pediatric world, they're followed very closely from birth, in
mhm,
terms of having surgeries very young, but it can be a very complex thing in terms of congenital heart disease.
Mm-hmm. Mm-hmm.
The one thing I will say, and that before we close, here, for example, at the hospital I work, we have programs where we do outreach. Our surgeons, for example, and some of our cardiologists go to places in Belize and other countries. And my hope is we can, eventually establish such a relationship in terms of Dominica. I mean, that would be a dream of mine
Mm-hmm.
in terms of being able to establish that kind of relationship where we can come down in terms of doing testing or support the hospital in any way we can, and fostering that type of collaboration in terms of improving access to things that we ordinarily wouldn't have, maybe, as you said, in terms of our population. I think I saw recently maybe there was a transvenous pacer that was actually put, may have been in Dominica or one of the other Caribbean islands, but my point is there is so much that is happening in the world of cardiovascular disease. And when you think about, the world itself, to me, we used to think of it as this, isolated place, everybody in their own region, but we're so much more connected in terms of virtual capacity, being able to look at things on screens and walk providers through that. Being able to, hey, there's some places where not even a doctor is doing some procedures. You train very good nurse providers, nurse practitioners, or advanced care providers in terms of physician assistants, and you have somebody that's dedicated and willing, that can bring so much to a team and to a hospital. So my hope is in the future there is opportunity for that. I think that would be wonderful.
Yes, it definitely would be. It definitely would be. As we seek to establish these connections, and we have so many people of Dominican descent, or
Mhm.
or Dominicans who have left Dominica and can
Yeah.
contribute in that way. Yes, in healthcare and in other fields
Mhm.
as well. So that networking is so essential. But Doctor, I am so happy that you were able to join us this morning here on Health Vibes. It is 11:31 a.m. and unfortunately we are at the end of our time. I had so many more questions. I wanted to touch heart attacks, which are some of the,
Oh
the
yes, yes.
yes, which is a common, another common
Mhm.
thing that
Yeah,
but I guess we'd have to schedule a follow-up
yeah.
show on heart health
Mhm.
because there are so many things that we could have discussed. But I'm happy with the time that we had and
Yeah.
with your giving us this time to really go into some of the things that we had the opportunity to discuss. So I will give you the last word. As I said, I apologize to the people who were trying to interact with you and didn't get that opportunity. But I'll give you the floor to close.
Well, again, I just want to end with a big thank you and a big shout out, Trudy, to this program, and using this as a platform to really educate everybody in terms of things that impact them. And I think it is a great way. Sometimes we think of ourselves just as we're just doing this simple task, or, hopefully this isn't having an impact, but well, hope that it's having an impact. And I think those small steps in terms of education, especially when it comes to the aspect of preventative care,
Mhm.
is so key. I always talk to my patients. I do a lot of outreach here in terms of churches and small groups, and really in terms of the aspect of generational health. We talk about generational wealth a lot, but not
Mhm.
generational health. And really, it starts with us, in terms of how we approach things, the habits we're willing to change, how we're willing to modify behavior that we pass on to our kids and to the future generation. And I think, as I mentioned before, I think that is so key when we think about how we use our resources, and also just in terms of the morbidity and mortality aspect in terms of our patients. So thanks again for the opportunity. I am certainly more than willing to come back for a second round in terms of talking about different aspects of cardiovascular care, but I feel like the time went by so quickly.
Yes, it did.
But
It did.
thanks for having me, and I am more than willing to support in any way I can.
Thank you so much. And to our listeners, that is the end of the road here for us on Health Vibes this Wednesday morning. We will be with you next Wednesday, God willing, with another show where we seek to really educate on some aspect of health and wellness and make it have a little vibes as well. As I like to say, it is Health Vibes. So see you next week. This is Trudy signing off. Until we meet again, see you. Goodbye.
Right. Right.
Your ads.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Langdo with co-hosts Jacinta Fagan Defoe and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday. So be sure to tune in. Health Vibes every Wednesday on Q95.